We will begin today's webinar, Approaches to Address Health Risks for Older Adults. Before we begin, we're going to go ahead and just share a quick disclaimer. In the meantime, 1 or 2 logistic notes for WebEx. If you do have any questions or comments throughout today's webinar, please submit them in the chat. You can see the little speech bubble icon at the lower right-hand side of your WebEx platform. You're able to send those questions directly to all panelists, and we will be monitoring those for our moderator throughout today's webinar to ask during the Q&A portion that will be held after the presentations towards the end of our call. To go ahead and get us started, I'm going to go ahead and pass the mic over to Amy Eden. Your cue, Amy.
Great, thank you. Welcome, everyone. My name is Amy Eden. I'm the director of AHRQ's National Center for Excellence in Primary Care Research, also known as NCEPCR. It's my pleasure to welcome you to today's webinar, but before we jump in, I just want to take a moment to say a few words of introduction about NCEPCR and highlight a few timely topic-relevant items. Next slide. NCEPCR is AHRQ's home for primary care research, and we've been focusing on 6 key activities really designed to help achieve NCEPCR's mission, which is supporting transformative primary care research, tools and methods for implementation, and the next generation of primary care researchers, all to improve the delivery of primary care. Next slide. AHRQ has a robust portfolio of work around healthy aging, much of which, as you might imagine, intersects with primary care. And I'd like to highlight a few recent items that may be of interest to you. And so first, in addition to our primary care R03 and R01 funding and opportunities, AHRQ released a special emphasis notice last year indicating our interest in receiving grant applications with a goal of improving care delivery, access, quality, equity, and health outcomes for older adults. Next slide. The second thing I'd like to highlight is AHRQ's Opioids in Older Adults Compendium, which is a change package designed to support efforts by primary care practices and healthcare systems to improve opioid medication management and prevent opioid use disorder in older adults. The compendium offers key activities with tools and resources that practices and systems can use in their improvement efforts. And you'll see we have a very relevant presentation today on this very topic. Next slide. And then finally, AHRQ recently released a request for information from the public to understand the effects of ageism on healthcare quality, services, and outcomes. We're interested in identifying efforts and innovative strategies and programs that really help mitigate ageism and optimize older adults' health. We hope that you'll consider submitting your comments and ideas in response to the RFI, which will be open until March 15th of this year. Next slide. Okay, so turning now to today's webinar, which will highlight the important role of primary care in optimizing the health and well-being of older adults. You can see the objectives of today's webinar here, which align with our presentations. So we have the pleasure of hearing from 3 AHRQ-funded researchers who will discuss their primary care research that addresses some key challenges in caring for older adults. So first, we'll hear about tackling the problem of care fragmentation by improving care coordination. Then we'll hear about addressing the risk of diagnostic errors with recommendations to improve diagnostic safety. And then finally, we'll hear about mediating the risk for opioid use disorder or overdose in older adults who are prescribed opioids for pain. Next slide. And now it's my pleasure to introduce our esteemed moderator for today's webinar, Dr. Arlene Bierman. Dr. Bierman is an internist and geriatrician and serves as the Chief Strategy Officer at AHRQ, leading our healthy aging work. Arlene will introduce our presenters and facilitate the Q&A and discussion, which will take place after all of the presentations are finished. So welcome, Arlene. I'll turn things over to you. Thanks.
Thank you, everybody, for joining us today. We really do have 3 outstanding presentations for you. And just as a quick background context, we are really on a collision course in healthcare between an aging population and the healthcare system that really isn't well designed to meet their needs. And primary care does have a critical role in providing person-centered, whole person care to older adults as they grow older. And really, it's the only solution to addressing this pressing problem. I'm a primary care physician and took care of many, many older adults for many years. And anyway, let me tell you about our presenters today. We have 3 primary care researchers. They will discuss their research on approaches to address health risks in older adults to improve care delivery for older adults in primary care. So join me in welcoming Dr. Lisa Kern, who will present on care fragmentation, care continuity, and care coordination, how they differ and why it matters for older adults. Dr. Ali Tran will present on the state of science and future directions to improve diagnostic safety in older adults. And Dr. Weill will present on unrelieved pain and the risk of opioid use disorder or overdose in older adults. Be sure to save your questions. We'll have a Q&A session after all the presentations are over. You can pop them in the chat as we go along, and we'll get to them at the end. And now I'm really pleased to welcome our first presenter, Dr. Lisa Kern. Dr. Lisa Kern is an associate professor of medicine at Weill Cornell Medicine. She's a national expert on healthcare fragmentation and a recipient of an AHRQ Mentored Career Enhancement Award for established investigators in patient-centered outcomes research. And her talk today will discuss the problem of fragmented care for older adults in the US and explain how her work on fragmentation informed the trial she's conducting for her AHRQ-funded grant. Lisa?
Thank you very much, Dr. Bierman. It is a great pleasure to be here today, and I look forward to hearing all of your questions at the end. Next slide, please. So it's often useful to ground a talk in a case. So here is a case which is technically hypothetical, but extremely typical of what primary care doctors encounter on a day-to-day basis. Let's say we have a 65-year-old woman with diabetes and coronary artery disease who comes to establish care with me as her primary care physician. She says she's switching primary care physicians because she recently retired and lost her employer-based insurance and now has Medicare. Her cardiologist, who is in a different health system with a different electronic health record, recently started new medication, drew blood for lab tests, and did an echo. But the patient does not have the details of what was prescribed, what was drawn, or what the echo showed. The patient also has an endocrinologist and an ophthalmologist who are in separate outside practices. The patient is not able to report exactly what those doctors are monitoring. Oh, and by the way, she went to urgent care last night for foot pain. So when I present this talk to primary care doctors like myself, they say this is extremely common. This is the bread and butter of primary care. It is both challenging and somewhat frustrating to be in a system where the different parts of the system don't necessarily communicate with each other. Of course, this situation is not unique to just starting Medicare. As this particular case shows, it's an ongoing challenge. Next slide. So my goal today is to explain why I believe fragmentation of care for older adults warrants more attention. You may be familiar with the concept of fragmentation, but in the literature, it's more common for investigators to discuss care continuity and care coordination. And I'm going to try to tease apart these different concepts. I'll illustrate how a focus on fragmentation can lead to novel ideas for interventions that would not necessarily be identified through the lenses of continuity or coordination, and then highlight how these concepts have informed an ongoing AHRQ-funded trial that is about addressing fragmentation of care through improving coordination. Next slide. So as I said, you may be familiar with these topics, but so that we're all on the same page, I'd like to define them. Continuity is the use of the same ambulatory physician repeatedly over time, such that the usual physician, who can be a primary care or specialist physician, accounts for a substantial proportion of visits. So I'll be using these icons in my talk to represent patterns of ambulatory care. You can see these are icons of different physicians. If the same icon repeats, it represents another visit with the same provider. So this patient had 5 visits, 4 of which were to the same provider, representing fairly continuous care. That seems straightforward. It's about to get more complicated. Next slide. Care coordination is the extent to which physicians are collectively operating in a team-like manner to develop and implement an overall care plan to meet the patient's goals. Coordination involves communication. You can see here we have one primary care physician, one specialist, and one patient who have discussed the patient's preferences and the options for his care, and they all agree on how to move forward. This represents coordinated care. Next slide. Now, while continuity and coordination are vitally important and have been topics of discussion for decades in primary care research, there are 2 big problems with them. First is that evaluations of previous care coordination interventions have shown that many of them have not been effective for a variety of reasons. And so there's still work that remains to be done. I would argue it's possible that many care coordination interventions and efforts to enhance continuity, which have been fewer, they may have been limited because they've typically focused on a small number of providers. Just like I showed in the previous slide, one doctor who is a primary care physician, one specialist, patient, family. That's usually the extent of it. And that approach may inadvertently omit many others who would be involved in the patient's care. Next slide, please. So to illustrate the extent of ambulatory utilization in the US, I'd like to draw your attention to landmark papers by my FOM and colleagues that were published in the New England Journal of Medicine in 2007 and in the Annals of Internal Medicine in 2009. And don't worry, I'm going to update these statistics in just a moment. But my and colleagues found that in the years 2000 to 2002, the median Medicare beneficiary saw 7 ambulatory physicians each year with an interquartile range of 4 to 11. I happen to love interquartile ranges to describe this problem because the number 11 in this case means that that's the 75th percentile, illustrating that 25% of people saw 11 or more ambulatory physicians in each year. And because different beneficiaries see different specialists, for example, Mr. Jones and Mr. Brown may see different cardiologists, the typical primary care physician in 2000 had 229 other physicians with whom care must be coordinated, equivalent to an additional 99 physicians for every 100 Medicare beneficiaries managed by that primary care physician alone, not counting any patients covered by Medicaid or commercial insurance. That is a humongous scope of care coordination, if you will. And as promised, I said I would update these statistics. Michael Barnett and colleagues found that, in fact, these patterns have only gotten worse over the last 20 years. The proportion of Medicare beneficiaries seeing 5 or more physicians annually has increased from 19% in 2000 to 35% in 2019. Next slide. So enter fragmentation. It seems that we cannot avoid it. Fragmentation occurs when there is ambulatory care that is so diffusely spread across many providers that no single provider accounts for a substantial proportion of visits. And there are many ways of mathematically describing fragmentation, which I won't go into today, but here's a brief conceptual approach that holds true. Here you have hypothetical patients, John and Ben, and their patterns of care. They both have 7 visits. which tells you that fragmentation is not about the number of visits, but rather the distribution of those visits across providers. John has 3 unique providers and Ben has 5. And you can see that John's most frequent provider accounts for 57% of visits, and Ben's most frequent provider accounts for 29%. Those are very different patterns clinically. So who has more fragmented care? The answer is Ben, of course. And there are millions of Medicare beneficiaries like him, probably 25% of Medicare beneficiaries. So focusing just on continuity or just on communication among a small number of people, while important, is incomplete. And we need to address the true complexity of what's going on in the US healthcare system. Next slide. So to reiterate then, continuity and fragmentation are measures of utilization. Those are patterns of care. Coordination is a measure of communication. And coordination can occur in the context of relatively continuous care, relatively fragmented care, both or neither. But I'm hoping that by defining them in these ways, the concepts are more precise. Fragmentation, of course, may be clinically appropriate, but it creates challenges for physicians and can cause harm to patients in the absence of communication. Now, you might say, well, I thought we have fixed this problem with electronic health records. And maybe we did improve the situation somewhat, but recent data show that the problem is still there. Lori Timmons and I, along with others, recently published a paper showing that even in the era of electronic health records, gaps in communication persist. We took data from a 2019 national survey that found that approximately 1/3 of primary care physicians, after the dissemination of EHRs, do not always or most of the time receive information back from a specialist after a consultation. These are physician level numbers, 1/3. So imagine how many patients that affects. Next slide. So I have been absolutely fascinated by this topic of fragmentation and very driven by the fact that we need to talk about it more because it does not seem to dominate the literature as much as these other topics. So I've now published more than 30 articles exploring this area, and some of the key findings have included the concept that there are more than 40 causes of fragmentation, according to patients and primary care physicians. There are also at least 24 different consequences of fragmentation, with 3 of those being desirable and 21 undesirable, including provider burnout. Quantitative studies that I've done have found that fragmentation is independently associated with more radiology tests, more emergency department visits, more hospitalizations, higher costs, and for some subsets of the population, more incident heart attacks and strokes. And by independent, that means that fragmentation is associated with all these outcomes, even after holding severity of illness or comorbidities constant, including through a whole host of primary data collection driven measures with detailed clinical information. Next slide. Despite how common it is for patients to see multiple physicians, there have been relatively few studies of fragmentation and very few interventions explicitly designed to address it. But if there are more than 40 reasons why it occurs, it's clear that no single intervention will fix the problem. So I'm pleased to share that my colleagues, Dr. Julie Bynum and Harold Pincus, and I published a viewpoint paper in JAMA Internal Medicine in 2024 with an AHRQ-funded framework that we hope will guide the development of novel interventions. Next slide. This slide is an adaptation of the table in our paper, which follows Dr. Pincus's 6P framework. This is not the only framework to use categories like this, but the application of fragmentation here is new. So you can see down the first column, there are different levels of action or different stakeholders, if you will, that all conveniently start with the letter P, 6P, patients, providers, practice settings, plans, purchasers, and populations. The second column shows how each level of action can contribute to fragmentation. And then the last column shows a potential intervention to address that contribution. This table is not complete by any means. It is meant to be illustrative of the types of interventions that we can start to think about if we look through the lens of fragmentation. This is a little bit oversimplified, of course, because at one level of action may contribute to fragmentation, and the intervention that we can envision may come from a different level of action, and that's great. But this kind of thinking has not been done before, and there's no existing inventory of potential interventions to address fragmentation, which we are hoping to generate. Next slide. So the AHRQ-funded trial that was mentioned in the introduction to this webinar is one iteration of the second row. It is a trial that is working at the level of providers, physicians, and others to address lack of communication among providers. And importantly, it is aligned with financial incentives from payers to improve communication across those providers. This is one, as I said, of many different interventions one can think of to address this row of the table. Next slide. So I'd like to share a couple of key features of this trial, which were informed by my work on fragmentation. And the trial is called Improving How Older Adults at Risk for Cardiovascular Disease Are Selected for Care Coordination. The study is set inside a Medicare Accountable Care Organization, or ACO, which has financial incentives from Medicare to improve care coordination. And it employs care managers or care coordinators to assist in this role. But those care managers and care coordinators are a scarce resource. There's not enough to go around. And there's no data yet on the empirical data to guide how to allocate those care managers to the people who may benefit the most, which is what this trial is designed to answer. It targets people with or at risk for cardiovascular disease, in part because that population often sees multiple specialists of different types, just like the case I started the presentation with. This trial uses highly fragmented care as measured in claims as an inclusion criterion. It is the first of 2 trials to do this. The other trial is also mine and is working to improve care coordination among people living with dementia. But the idea of even targeting an intervention at people with highly fragmented care is new. The trial proactively asks patients if they think their care is well coordinated, and then, if not, immediately offers assistance. Previous studies have asked people if they think their care is well coordinated, but usually that information is used as population level quality measurement, but not as an individual information that is immediately actionable, and that's how we use it. So we offer the assistance of care managers who are already employed by the ACO to address any perceived gaps in communication. So I'm hoping you can see that this trial is distinctive in several different ways, building on the work that I've presented thus far. Next slide, please. So the results of the trial are not yet available, but I can say already that there's no consensus in this space on whether interventions in general should decrease fragmentation or ameliorate its potentially harmful effects. But the problem of fragmented care does not seem to be going away. It seems to be getting worse in our country, and it requires urgent attention because patients, especially older adults, are encountering preventable harm. Primary care has a huge role to play in the solution, but primary care also cannot do this alone. Primary care physicians are excellent at providing continuity and facilitating coordination, but primary care physicians also try to function in a system in which specialists are referring to each other without going back to primary care, and there are many other reasons why it's difficult for primary care physicians to overcome the systems-based challenges by themselves. So we need systems-based solutions in part. I would love to help facilitate national discussions and more health services research to develop, test, and implement new strategies to address this critical problem. Next slide. I'd like to thank the Agency for Healthcare Research and Quality enormously for supporting this work, along with the National Institute on Aging's Impact Collaboratory, my co-authors on the Viewpoint paper, Julie Bynum and Harold Pincus, and many, many collaborators at Weill, Cornell Medicine, and New York Quality Care, too numerous to fit on a single slide. Thank you so much, and I look forward to the discussion at the end.
Thank you, Dr. Kern. Actually, geriatricians have a name for that. We are all familiar with polypharmacy, and we call it polydoctoring. And it really is a key problem to tackle. And now we're going to turn to Dr. Alberta Tran. And Dr. Tran is a senior research scientist at the MedStar Institute for Quality and Safety. She's an assistant professor of medicine at Georgetown University Medical Center and adjunct faculty at the University of North Carolina Chapel Hill School of Nursing. She has a background in critical care nursing, quality improvement, and health services research, with her current research focused on co-designing and evaluating solutions for improving diagnostic quality for older adult populations. Dr. Tran's presentation provides a summary of the state of the science around diagnostic safety in older adults and highlights current efforts and resources to reduce diagnostic errors in primary care settings. So welcome, Dr. Tran.
Thanks, Dr. Bierman, and thanks to NCEPCR for the opportunity to share my work and everyone here for joining today. Dr. Kern provided a really nice summary of the problem of care fragmentation and some of its impacts on quality and preventable harm in older adults. And so I'm gonna kind of build off of that and share for my goal for today's presentation is to describe my work on an area of quality called diagnostic quality and to share some recommendations that I have around improving diagnostic safety for older adults in primary care settings specifically. Just to kind of ground us for this talk, diagnosis is really important in primary care because these settings are often a patient's first point of contact for a health problem. And so because of this, it's really important for primary care teams to build their capacity to reach a timely and accurate diagnosis or an explanation of what's going on with the patient, as this really sets the entire trajectory for early treatment and appropriate care and ultimately improved health outcomes for patients. Next slide, please. The diagnostic process, however, is really complex, and in fact, it's one of the most challenging aspects of medical care. Diagnostic errors occur when a patient's diagnosis is missed altogether. So we think about, for example, missing a cancer diagnosis, or when it's delayed. So for example, not recognizing like early signs of sepsis or dementia. Missed or delayed diagnoses are estimated to affect about 1 in 20 adults in the US, or nearly 12 million adults in the US each year. And so not only is it a prevalent error, we also know that these errors are associated with serious preventable harm and death from chart reviews and medical malpractice claim reviews. In primary care specifically, researchers have found that about 79% of diagnostic errors are related to process breakdowns that occur during a patient and provider clinical encounter, with about more than half of these related to problems with history taking or data gathering and synthesis, which I'll talk a little bit more in the next slide. And then meanwhile, diagnosis in older adults in particular is really important to study because at a population level, we're seeing people live longer. We're seeing the population of those over the age of 65 rapidly increasing. And we know that older adults are at a high risk of experiencing a diagnostic error in their lifetime, but also are at a higher risk a higher risk of experiencing a diagnostic error at any point because of a number of contributing factors due to their age, which really was the motivation for our review. Next slide, please. Diagnostic safety has received a lot of research attention and effort in the last decade, which has really catalyzed our understanding of it. In 2015, the National Academies for Science and Engineering and Medicine released a new Improving Diagnosis in Healthcare report, pictured on the left, that highlighted key issues to addressing diagnostic errors and included a number of recommendations from subject matter experts to really build momentum and research in this area. Their definition for diagnostic errors is provided here, as well as the diagnostic process framework, which it's really important to note are taken from a patient's perspective. So because of that, the definitions for diagnostic errors have moved to not only include delayed, missed, or wrong diagnoses, but also situations where diagnoses might not be communicated to the patient or understood by them. The diagnostic process that's illustrated here thus starts with first the patient's perspective, the patient's experience and recognition of a health problem, and then their decision and ability to engage with the healthcare system before we move into this iterative cycle of patient clinical team interaction, where a lot of the process breakdowns that I spoke to in the previous slide in primary care can occur. Once a working diagnosis or several working diagnoses are determined, then it needs to be appropriately communicated to the patient and understood before proceeding with treatment. And then oftentimes this process has to be revisited several times before we can reach an appropriate diagnosis and achieve the improved health outcomes. Next slide, please. So therefore, using the definitions and the diagnostic process framework that came from that report, we really wanted to perform a literature search and summarize what's known in the science around contributors to diagnostic errors in older adult populations. There have been a lot of key efforts in the past that have had some similar objectives. I've highlighted two here. First, a workshop in 2022 that brought together experts to highlight key challenges and considerations for diagnostic excellence in older adults. And also, second, in 2016, a team of researchers published a rigorous systematic literature review looking at the incidence and potential causes of diagnostic errors in 7 common diseases that impact older adults. So what we wanted to do is build off of these key works and offer a more recent and comprehensive summary of the state of the science with a focus on diagnostic safety and being able to identify opportunities for practice improvement, research, and policy. Next slide. Due to timeline constraints, we deployed a rapid review methodology of 5 databases. And I will mention we're currently working on a rigorous systematic review over a longer period of time with a similar objective that we hope to publish this year. We included any articles that were related to diagnostic errors or diagnostic processes in adults over the age of 65, and we focused on papers that were published in the last 10 years. We excluded any articles that were not in English, were focused on the wrong population, or focused on diseases that didn't impact older adults, or didn't directly involve an aspect of the diagnostic process framework that I shared earlier. Next slide, please. We extracted information from over 100 articles, and we describe these findings in the AHRQ issue brief that's pictured on the left. What we did is we really grouped our findings by patient, clinician, and structural factors to help consider recommendations and next steps at each of these levels. I'll share some quick thoughts on each of these points in the next slide, but I will move kind of quickly in the interest of time, and we'll share the full issue brief in a link in the chat that has more details. Okay, so first at the patient level, we found a number of studies that described how diagnosis is really challenging because older adults can have more atypical presentations of common medical conditions. So for example, sepsis in this population is often under-recognized, but older adults with sepsis often present with nonspecific symptoms like altered mental status, lethargy, or loss of appetite that can make having an early diagnosis of sepsis really challenging. Similarly, multiple chronic comorbidities, multiple chronic conditions or comorbidities, which we see in about 4 out of 5 older adults, can affect the presentation of new diseases and really obscure the clinical picture that makes it challenging for a clinician to reach a diagnosis. Additionally, several studies have described how communication barriers due to hearing loss, vision impairment, cognitive impairment, or language barrier issues can additionally impact the diagnostic process. Other studies have described how functional decline and health-related social needs like a lack of access to public transportation, frailty, or functional impairments further reduce older adults' access to healthcare services or their ability to follow through on appointments that are needed to move forward with diagnosis. And finally, we found that polypharmacy is a contributor to diagnostic errors in older adults, adverse drug events from medications sometimes mimic acute medical conditions and may contribute to a prescribing cascade where other potentially unnecessary drugs are prescribed in response to these symptoms from other medications, and then overlooking kind of new diagnoses that might be occurring. At a clinician level, we found several contributors to diagnostic errors in the literature. Ageism or biases around age can impact clinicians' abilities to provide accurate and timely diagnoses. I do want to mention, while we included this as a clinician factor, this can also be a patient factor. And we see this through what's called internalized ageism, where patients might think that a change in their health is just a result of getting older and might not choose to report this change or symptom to their healthcare provider, which then impacts the provider's ability to really get an understanding of what's really going on and move towards diagnoses. Other clinician factors that we identified in our review include challenges and time constraint factors that might limit a clinician's cognitive abilities or ability to perform a thorough chart review or review information, over diagnoses, or when a clinician might order a diagnostic test or screening despite a lack of clear benefits for the patient. And finally, communication barriers, similarly to what was talked to with patient factors, but communication breakdowns that occur between team members or between the patient and the clinical team, where really important information isn't relayed appropriately or gets entirely missed. And then finally, we identified several structural and organizational factors contributing to diagnostic errors. First, historically, studies might not include older adults in the validation of laboratory diagnostic or screening tests, but we're really seeing in the past 5 years a lot of efforts to improve the diagnostic accuracy around these kinds of tests, and particularly around geriatric symptoms and syndromes and issues. Also, care fragmentation, as Dr. Kern described in her presentation, can result in suboptimal quality and outcomes, and particularly around diagnostic quality due to some of the communication breakdowns that I mentioned before. And finally, a really urgent and important problem structurally in the US is the increasing need for more geriatric specialized physicians, nurses, and other healthcare professionals to support diagnosis and care for the older adult population as it continues to rapidly grow. Next slide, please. So I want to close out my presentation with some recommendations for primary care that we've identified based off of the findings from this review. First, because we know a large proportion of diagnostic errors in primary care occur during this history taking and data gathering level, a lot of my team's recent efforts have been around developing interventions and testing interventions to meaningfully engage other diagnostic team members, especially for older adults, not only the older adult patients themselves, but also their family members and caregivers. And this is really important because these patients and families and caregivers and diagnostic team members have sometimes key diagnostic information that needs to be communicated during a clinical encounter, and that can help inform an early and timely diagnosis. I will mention there's a number of AHRQ-funded interventions that have been developed to improve information sharing and communication and to build diagnostic team capacity. Some of these include a Team Steps diagnostic team-based training that helps team members to understand their roles in the diagnostic process, and then also patient-facing toolkits like the communication note sheet that's pictured here that is designed to help patients pull together their health stories and communicate them at the time to their provider to help move diagnostic communication forward. Providers and clinical teams can also consider environmental modifications and interventions to help overcome some of the communication challenges that patients might experience at the time in sharing what's going on, and can also deploy communication interventions to address care fragmentation. Another future direction for improving diagnostic capacity in primary care is the expansion of health information technology and other interventions to improve diagnostic processes. We know that improving EHR, or electronic health record interoperability, particularly around the integration of medication data, can help reduce this risk of prescribing cascades and polypharmacy that contribute to diagnostic errors. Also, many primary care settings and healthcare systems are designing or are already deploying decision support tools for clinicians that have demonstrated to be really promising solutions for helping providers quickly access diagnostic information or get diagnostic suggestions and achieve diagnostic accuracy. And then finally, in the policy arena, there are already a lot of national and organizational initiatives aimed at improving care for older adults more broadly that also will help improve care for older adults across the diagnostic continuum. Most organizations have some kind of a safety surveillance system already in place that can be tailored or honed in a little bit more to better understand diagnostic errors and near misses. The John A. Hartford Foundation's National Age-Friendly Health Systems Initiative and their 4Ms framework also has important implications for improving diagnosis, and we describe this a bit more in our report. And then finally, because of the importance of primary care and all of the unique challenges that older adult populations face in diagnostic safety, it's really necessary that we continue efforts to improve geriatrics training and education and expand our geriatric specialized primary care workforce so that we can move the needle forward in improving diagnosis for older adults. Thanks, and I will end there and take questions at the end.
Thank you, Dr. Tran. So now I'd like to introduce our third presenter, Dr. Jenny Weill. Dr. Weill is an associate professor at the College of Pharmacy in the Ohio State University with training in geriatric pharmacoepidemiology. Her current research focus is on pain in aging, and she's led multiple federally funded studies, including 2 from AHRQ, to evaluate pain management in older adults using large data approaches. Dr. Weill is presenting today on unrelieved pain and risk of opioid use disorder or overdose in older adults who are prescribed opioids. Go ahead, Dr. Weill.
Thank you, Dr. Biersman. It's my pleasure to share with you the work that is currently funded by AHRQ. Next slide. So I would like to start with giving you an overview of opioid use disorder and opioid overdose in older adults. So when we think about OUD and OD, we typically think about this as the problems that occurs in younger adults, working age populations. However, older adults can be at risk for OUD and OD because many of them had reported the chronic pain and received a prescription opioid for managing their pain. So when we look at the recent statistics, OUD prevalence is 16 per 1,000 older adults, and OD instance is 1 per 1,000 older adults. It is important to emphasize that 98% of OUD and OD events in older adults involve prescription opioids. And in other words, the vast majority of older adults experience OUD and OD from taking prescription opioids. And while the instance and prevalence of OUD and OD seems relatively small compared to younger adults, their increases are substantial. According to AHRQ report in 2008 on hospitalizations and the emergency department visits due to OUD and OD, and our studies in instance diagnosis of OUD and OD in older adults, as well as other studies that are not listed here, all pointed out increased trends in OUD and OD in older adults in the last 2 decades. And these upward trends continue to increase despite of great efforts that has been put in place to curb prescription opioids. Next slide, please. So the increase in trends in OUD and OD in older adults has prompted a lot of studies looking into risk factors. These are the known risk factors that have been commonly mentioned in studies in older adults. However, it is noted that these factors are not fully predicting of OUD and OD in older adults. And also with the decline in opioid prescribing and the high risk and unsafe prescription opioid use are also declined as well. And that really prompts us to think about risk factors other than opioid prescribing that may contribute to OUD and OD in older adults. And we know that unrelieved physical pain after prescribed opioids has been hypothesized to be risk factors of OUD and OD. So in 2015, National Survey on Drug Use and Health reported that 4 of 5 older adults misuse prescription opioids in order to relieve their pain, compared to only 66% of their younger counterparts. And qualitative study also interviewing older adults also revealed that unrelieved pain is a common pathway to OUD. And yet there's no empirical population-based study that have been quantified to what extent unrelieved pain has been associated with the OUD and OD in older adults. Next slide. With that, that brings to our research-specific aim, which is to examine the associations of pain status with risk of OUD and OD among older adults with prescribed opioids. We assess pain status in 2 measures, uncontrolled pain and high-impact pain, which we will talk about their operationalizations in a minute. Next slide. So here's our study source. We use Health and Retirement Study, HRS. It is a national longitudinal survey of a random sample U.S. older adults living in community. HRS starts in 1992 and conducted every 2 years, with each wave including approximately 17,000 participants. And close to 90% of HRS participants consent to link to their Medicare claims data. We use HRS linked Medicare data from 2006, which is the year where Medicare Part D implemented, up to 2022, which is the most recent year of Medicare claims data linked to HRS. We use HRS survey because it provides information on pain status, which is our key exposure. As well, HRS provide some patient-reported clinical measures, including depression and physical functioning, including ADL and IADL. We use a linked Medicare claims data to identify the instant diagnosis of OUD and OD, which is our key outcomes. And we use the prescription opioids to identify our key study population. Next slide, please. So here's how we measure pain status in HRS. Each participant responded to these 3 questions related to pain. Are you troubled with pain? How bad is the pain most of the time? Mild, moderate, or severe? Had pain affect any of your daily activities? I will then use the first 2 pain questions for our primary pain exposure, where we classify patients as uncontrolled pain if they reported moderate or severe pain, or otherwise they had a controlled pain. Our secondary pain exposure is high impact pain, defined as having uncontrolled pain plus the pain affecting the daily activities. Otherwise, they have no high impact pain. Next slide, please. So here's how we measure our OUD and OD outcomes. To capture opioid overdose event, we rely on the diagnosis codes of opioid poisoning that coded in inpatient, outpatient, or emergency department encounter claim. To capture OUD, we adapt a relatively conservative algorithm developed by previous studies in order to increase the chance of capturing true OUD cases. So the algorithm include these 4 different definitions, which involve diagnosis codes for OUD dependence or misuse, as well as involve encounters with injection drug use related infections or rehabilitation or detoxification care. For definition 2, 3, 4, we required at least 2 claims that occur with 3 months of each other, with the first claim indicating the presence of an OUD event. Next slide. So here's our study design framework using HRS linked Medicare cohort. We first, for each participant, we first identify the first HRS pain report, which can occur between 2008 to 2020 HRS survey. We designated this as a cohort entry. We then apply these 7 eligibility criteria during a 2 years look back period from cohort entry. During the same period of time, we also assess covariates, which are listed here. Some of the which are also measured during follow-up as time varying covariates. For each participant, we then follow up them from cohort entry to one of the sensory points here. OUD and OD outcomes are followed up in separate cohort. And because individual pain tends to change over time during the follow-up, we treated the pain measures as a time-varying exposure. Then we used the advanced statistical modeling called marginal structural modeling to account for the time-varying pain status as well as time-varying covariates in the Cox model. Next slide. So here's our findings. We identify about 3,000 older HRS Medicare participants with a diagnosis of chronic pain and receive at least 1 prescription opioids at cohort entry. The mean age is 76 years. Majority of them are female. Of the identified sample, 43.8% had uncontrolled pain, and 33.6% had a high impact pain at cohort entry. And over time during the follow-up, we will observe the uncontrolled pain and high impact pain increase over time. And using the 13 years data from 2008 to 2021, we observed a mean duration of follow-up of 6.4 years in both the OUD and OD cohorts. Next slide. So here's the findings of adjusted associations of uncontrolled versus controlled pain and OUD and OD risk. So the figure A and B here are survival curves. Y indicates the probability of individuals who remain event-free, and X here is times in years. And survival curve here, the lower the curve, the worse the outcome is the worse the outcome is in the specific pain group. So figure A and B illustrate that compared to the uncontrolled pain versus controlled pain patient, the probability of remaining OUD, OD event-free was lower. And when we look at the adjusted hazard ratios, we observe that the uncontrolled pain group versus the controlled pain groups has a 9.7 more likely to have OUD events, and they also have 2.46 more times more likely to have OD events. We also conducted the sensitivity analysis that adjusted for censoring due to death, and we observed a similar result for OUD and OD. Next slide, please. So here's a finding for having versus having no high impact pain and OUD and OD risk. Again, the figure C and D here are survival curves. The lower the curve, the worse the outcome is in the specific pain group. And figure C and D shows that the probability of remaining OUD and OD event-free was lower in patient with versus without high impact pain over time. Looking at the adjusted hazard ratio, the patient with versus without high impact pain has a 6.7 times higher likelihood of having OUD and the 1.96 times higher risk of having OD. And the sensitivity analysis also showed a similar results. Next slide, please. So our study contributes to the existing literatures by providing prevalence of unrelieved pain in older adults with prescribed opioids. We observed that 2 in 5 older adults experience uncontrolled pain, and 1 in 3 older adults experience high impact pain. Our study also showed that unrelieved pain has great impact on OUD and OD. Both uncontrolled pain and high impact pain are significantly associated with OUD and OD risk, with the hazard ratio ranging from 2.0 to 9.7. And we think the underlying mechanism is that the persistent unrelieved pain after receiving prescription opioids increase patients' opioid use and their dependence on opioids. And therefore, they may use the prescribed opioids in ways or for reasons other than as prescribed, and therefore increase the risk of OUD or OD. Next slide. So based on our findings, here's a clinical message to clinicians, including primary care doctors who often see patients with pain. So our study really underscores the importance of regularly monitoring pain after prescribing opioids to patients. We think it may be important to include unrelieved pain as one of the key component indicators, along with other already established risk factors of OUD or OD, to assess the need for continuing prescription opioids for patients. And for older individuals whose pain remains unrelieved after receiving prescription opioids, we think it may consider non-opioid therapies in order to reduce the risk of OUD and OD in older adults. With that, that ends my presentation. Thank you for your attention. I'm looking forward to the discussion.
Well, thank you to all of our presenters. That was a lot of information, and it does raise a lot of questions about the role of primary care, the support that primary care needs to do this. Somebody put a comment in the chat about the need for geriatric training for primary care physicians. And, there's a lot of different models for that. And HRSA actually supports the GWEPs, the Geriatric Workforce Enhancement Programs. There's 42 across the country that specifically focus on how do we increase competency in primary care to take care of older people. But people also need structural supports. And there's a lot more. So feel free to put your ideas in the chat as well. And, I'm going to start with a question. I think, just thinking about the 3 presentations, they were all terrific. And they're really 3 different methods for primary care research: an interventional study, an evidence review, and a secondary data analysis, and how we need all of these to really improve care. But maybe I'm going to ask Dr. Kern, I'm going to start with you, because AHRQ has a big initiative to advance person-centered care planning. And how do we do it, that's not just the one team in primary care, but across all of the care team that's taking care of a patient. So could you tell me a little bit more about how your care coordinators interface with both the primary care team and also with the specialists?
Sure. I thought you were going to ask to speak more about how the care managers were being patient-centered, which is where your question started. So I will answer both, which is that, as I mentioned, most studies have not used patient satisfaction with care coordination as an actionable piece of data. And so we have our care managers reaching out to patients to proactively understand if they're having problems. And then if they are, then the care manager will use their usual skills to reach out to the primary care physician, to the specialist, and to try to resolve whatever apparent gap in communication exists. I think that one notable piece of feedback that we were getting from our care managers is they were asking if we, as a study, expected them to reach out to people in other health systems, which is not what they were necessarily used to doing. They're like, well, the patient has a cardiologist, but the patient's cardiologist is in a different health system. Do I still have to call them? Yes, please. And so I think that we're trying to break down barriers across providers, and it turns out also across health systems. So I hope that answered your question. If not, I'm happy to elaborate further.
Yeah, actually, there's a question for Dr. Tran, right? About the use of AI in clinical decision support systems, and how that, have you seen this clinical decision support helping reduce, diagnostic errors or advanced diagnostic excellence?
Yeah, great. Thanks. I was working on a chat response, Dr. Bierman. So thanks, Christopher, for the question. And yeah, I mean, I also have been optimistically following, and there's tremendous potential in the use of clinical decision support just broadly, with, I think, untapped potential for diagnostic errors. We haven't seen it towards diagnostic errors in older adults specifically, but there is a lot of effort towards using clinical decision support for diagnostic safety generally, or for specific diagnoses, especially in hospitals. And so with that, older adults are included in that, and I think have additional considerations for what these clinical decision support systems, how they're being deployed and tested and checked. So it's a very, I think, important question, and I would say maybe stay tuned.
One observation I had was sort of the relationship between your presentation and Dr. Wei's, because I think ageism often gets in the way of diagnosis of opioid use disorder in older adults. That people just don't assume that that's going to be an issue and miss that diagnosis. But I want to just really emphasize to everybody, what Amy had showed before is our compendium with resources. There's a lot of evidence-based strategies to mitigate the risk of opioid use and misuse in primary care settings. And actually, maybe Dr. Wei, you could comment a little bit more about sort of the role of pharmacists and how you interface with primary care and what you see as some of the solutions to this problem.
Sure. So for older adults, that's what I focus on. As I mentioned, a lot of them experience OUD and OD because of prescription opioids. That's very different from like a general younger adults, which they have their sources of becoming OUD and OD. So in pharmacists, I think what they can do is really look at the prescriptions prescribed by the doctors to see, is the patients continue to increase their dose. That's one thing that has been established risk factor for OUD and ODs. And then and then maybe communicating with the patients a little bit to see and how does the pain medication work for you. Do you still feel pain? So kind of get a little bit information, and then hopefully there is a kind of channel communicating between pharmacists and the primary care physicians. If pharmacists see some kind of a red flag, but I think if primary care physicians are again a really important role here because they are often in the front line seeing those patients. I happen to kind of shadow a lot of some of the PCPs seeing pain patients. So when they prescribe opioids, and I heard a lot of physicians saying, opioids are not really the bad medications as long as you are using in the appropriate ways. So here we are seeing my study saying, really monitor the pain. I think it's very important to see if the medication is working. I also looking in the chat, and one of the comments was talking about counterfeit pills purchased online. I I'm not aware of. I think I'm aware of this, but I don't know where we can get the data because it's usually not recorded. So I'm not sure if it's really popular or prevalent in older adult population.
Yeah, so there's another question for Lisa, but there's one more for you. So let's stay on the opioids for a minute from Donna Lisi, that, you know, under treatment of pain as a problem too, you know, for people who don't have misuse, but because of the fear of abuse, people might be undertreated.
Yeah, that's excellent questions as well. So I think that's a kind of some works really the communications between the patients and physician as well, you know, and you know patients they will just honestly reported their symptoms and how they use the medications. And then hopefully I know in the past couple of years, because of the clinical guideline and all the regulation, they are limiting the prescription opioids and all the kind of enforcement. So physician on that side kind of on very defensive side, they don't want to take new patients. They are kind of restricted the opioid prescribing as well. And with the opioid prescribing is declining right now, I think it's time to think about why the OUD and OD still increase. So maybe it's not a fault of prescription opioids, I think. And so maybe we need to turn our attention to something else. And that's, I think, the purpose of my study really, you know, again, if we see some consistent unrelieved pain after prescribing opioids, we need to really pay attention to that, not just continuing prescribing it. But if patient, they are good, you know, their pain control, they are happy with the medications, and then so, you know, prescribing opioids is not a big issue, and in fact it should be, and in order to prevent the untreated pain. That's my opinion.
Yeah, so our compendium gives a lot of alternatives, you know, for pain management, you know, including, you know, physical activity, physical therapy. And, you know, I think one of the problems is access to non-pharmacologic therapy, because there's a lot of evidence for a lot of, you know, a comprehensive approach to pain management. And it's often a challenge for primary care doctors not having access to those services, or their patients not having access to services that could help them manage their pain. So I'm going to actually move over to Dr. Kern now. So you talked about, you know, fragmentation among doctors, you know, sort of having multiple doctors. And one of the questions is, what about fragmentation, you know, when people are getting drugs from multiple pharmacies? And that's another type of fragmentation. Has anybody looked at that?
It's a really interesting question. I have a new grant that will study polypharmacy and polyprescribers, as Dr. Bierman had mentioned. So I'm hoping to look into that with Part D data from Medicare. But I can say in other studies that we have done, we find that there are problems with medication. So if you think that the way fragmentation could cause harm is through gaps in communication, and those gaps in communication then lead to errors in management. One of the most common errors in management or difficulty with medication. Sometimes that's on the prescriber side, sometimes on the pharmacy side, sometimes on the patient side. You know, one common scenario we've heard about is where different doctors that the same patient will see will change, like two different doctors are managing the same thing, like hypertension, and one doctor will change the dose of the medication. So let's say from 10 milligrams to 15 milligrams. So they'll prescribe a 10 milligram tablet, and you know, or decrease is a more common example. Go down from 10 to 5, right? So they have a 10 milligram tablet and a 5 milligram tablet. But the patient doesn't realize that the 10 milligram was discontinued. So they can still have it at home, and then they wind up taking 15 instead of taking 5. So, and that's an opportunity for pharmacists to intervene with education about, no, this is the new dose, throw out what you had, or bring back to the pharmacy what you had. So I think that the issue of pharmacists and medication prescribing and management is highly relevant to fragmentation, and there's a lot more work that can be done in that area.
Yeah, no, that's great. And actually, one of the solutions that AHRQ is working on is our, e-care plans, which are Smart on Fire apps that are accessible to clinicians, to the whole clinical team, to patients and caregivers. And so, for example, what they could do is aggregate data from multiple EHRs. So it would flag that. It would put them all together and say who changed what and when, and to make it easier, because it's near impossible in a quick clinic visit to get all this information and sort this out. And sometimes you don't even know that the patient might, be taking double, it's therapeutic duplication, right? Of just taking too much. So that's great. Okay,
and I just want to add too, because I've been thinking a lot about this lately around the diagnostic implications. It actually came up a bit in some focus group work that we were doing with older adult patients in primary care around, I see my provider with this problem or my specialist with this problem, and I don't necessarily think it's important to relay that information to my primary care provider. And there's this misconception sometimes that, especially with the electronic health record, or especially if they're seeing providers within the same care system, that patients have that think everything is communicated and shared in this, interface. And I think it's really important to highlight that that's not always the case. I mean, Dr. Kern, especially with your work around fragmentation, and the question that gets posed kind of with us is like, who's the main coordinator for this? Is it the primary care physician who's kind of, some of my colleagues have said, we're the quarterback of it and bringing together this information? Or is it the patient's responsibility to kind of be empowered and be able to bring that information together and synthesize it? And so really, I think trying to think through tangible and pragmatic interventions that can be deployed around that are really important for both diagnostic considerations too.
Yeah, and this is why everybody needs somebody who's, can help, sort of be their primary physician and coordinate care, whether it's a primary care doc or somebody who's mostly a specialty care. But unfortunately, in our system, that doesn't happen. And I think, the solution is, and, people who, are pressed for short visits, don't have, team support to do this. And the real need to invest in primary care and strengthen primary care and provide the resources and the time and the capacity for primary care physicians when it's, when it's their role for a particular patient to be able to do this. And right now it's just so hard. But I think to end on a more positive note, I think the good thing is we know a lot. There's a lot of evidence. And we know we can improve care to older adults, and we know that primary care can play a really key role in doing this. So, I want to thank all our presenters who were all fantastic, and thank you to everybody for joining today, and thank you for your questions.